So as you rightly pointed out, we will straight away jump to the workshop framing itself. And I will share some of the experiences that we have had in past year or so with regard to tuberculosis that will really build up us for the workshop that is there in the later in the day. Of course, the night for me. My first experience is that I'm sharing is that of a patient that we saw in September 2025. This was a case which was presented by one of my MD students. If you look at the sickness career graph of this particular patient, you will see that within a period of 2 years, the patient reported to us thrice with same symptoms. So he was a patient of tuberculosis, treated twice before he reported to us for the third time. He was treated, considered cured. He got back to to the environment that he was living in and came back again with the same symptoms. A young man, no risk factors otherwise, but just the fact that he was picking up infection repeatedly. The second experience that I'm sharing with you is that of what we did in the district wherein my medical school is located. Now, the district has a population of around 1 million, 1.5 million, 1.5 million. And what we tried to investigate was how exactly the data is panning in terms of the risk factors that are classified for tuberculosis. This is the approach which is being followed world over. They give you a list of risk factors and you identify patients on the basis of these risk factors, screen them, treat them, and report whether they are cured or not. So what we did was this district generally reports around 3,000 cases a year. We screened around 2,664, the database of 2,664 TB patients in the district, and found that traditional risk factors were present in only a minority of patients. So you didn't find a lot of diabetics, you didn't find a lot of obese patients, you didn't find a lot of malnourished patients, you didn't find a lot of very old patients. Most of the patients who came to us in this database were between the age of 20 to 59. So the traditional concept of identifying patients based on certain risk factors was defeated when we looked at this data. The third is an experience which was real world. We wanted to see whether this data which we captured for the district through the portal itself reflected in real world or not. So what we did was we wanted to do a community-based assessment or community-based screening, which was something in our mind since the Unpolitics meeting of 2025. So we wanted to go to the community, see how exactly these high-risk factors pan out in the population as such. We identified around 146 villages and thought of catering to more than 100,000 households. On the basis of preliminary investigation, which was carried out by our field-based workers, we identified around 20,207 high-risk individuals. Now, these high-risk individuals were listed as part of the traditional risk factor checklist that is available world over. Diabetics, HIV positive patients, patients of CKD, patients of on treatment for malignancies. So these all were listed as high-risk individuals, and we identified around 20,207 of such individuals. But we were surprised when we asked these 20,207 of high-risk individuals to come to our community-based camps, wherein we would do the further screening. We will evaluate them for their tuberculosis status. Very few of them turned out. Out of these 20,207, 8,000 roughly turned out for X-ray examination. And when we told them that some of you will need to be investigated further through our sputum microscopy, through our CBNAT test, you'll be surprised that only 650 patients agreed to these investigations. And out of these 650 patients, we could find only 2 patients of tuberculosis, meaning we were missing a lot of them. So initially, we thought we will be identifying around 100 patients based on the notification rates that are there for our district, but we zeroed down and found only 2 patients. Besides the fact that we identified high proportion of extrapulmonary tuberculosis as a common cause, or the fact that camps were held on weekdays, with which we were missing the working population. But there were certain other factors which were responsible for the low yield that we were finding through our camps. One was mobility as a barrier. So mobility barrier prevented uptake among vulnerable groups. So you had patients who were actually suffering from the disease, who were actually having the risk factors. So patient of malignancy who couldn't end up in our camp. So that was one of the reasons that we had a low yield. Second is the significant stigma which is around TB testing and disclosure. So once people would come to the camps, they will be identified as TB positive, and that disclosure will in itself ensure that they are stigmatized. So these two were primary reasons which we identified besides the high proportion of extrapulmonary tuberculosis as a reason that we couldn't find the number of patients which we were expecting to find based on the preliminary data or the preliminary notification rates for the district. Now, where does this lead us? It leads us to the fact that there is a clear-cut surveillance gap, and we need a new approach as far as identifying patients is concerned and treating patients is concerned. So what do we suggest? So within the workshop, we'll talk a lot of things, not just one thing, because we believe that a single response, a single answer will not be able to answer all the questions that are being raised by tuberculosis across the world, and we will need a multi-layered approach to take care of tuberculosis. But we began with one thing which is almost in the process of implementation at this point in time. We have secured the funding, we have secured the response from the government on that, and we are building a low-cost, locally manufactured air sampler. It is a device that could sit in a household, shelter, prayer halls, prisons, or garment factory for 48 hours, collect ambient air on a membrane filter, and be retrieved by an ASHA worker on her next household visit. Now, these ASHA workers are village-based workers. They go house to house, acquire the data on tuberculosis on a monthly basis, so they can be given this job. So is this doable? Can this be done? Given the way our public health system is panned out in this country, it is very much doable. And our preliminary work suggests that this can be done. But as I said, there are more questions which need to be answered. And the questions arise from the three examples that I have already provided to you. One is reactivation versus reinfection that will be taken up in the workshop that we are planning later in the day. That's all I have for the talk. If there are any questions that I'm happy to address, we will meet in the workshop and we'll thrash them out. Thank you. Thanks a lot. What I will do over a period of time is that I will introduce with a few slides, primarily for two reasons. One, because most of us who are sitting here are not actually public health or medical people, so tuberculosis may not be something with which they are quite familiar. And second, tuberculosis is more my problem than the problem of the world at this point in time. So I would just roll out certain things on tuberculosis, and then I will raise certain discussion questions that we can discuss and come to certain conclusions if we are able to. So this is how we start. The idea of this workshop is to rethink tuberculosis. And we need to think about tuberculosis beyond the biomedical model. We need to think about its physics, environment, and systems thinking. Why we need to do it, we will, over a period of time, we will go through that as well. But before I talk about this in detail, I need to remind people that TB kills around 1.3 million people in year 2024 only. It's the number one infectious cause of death across the world. And yet, as I said, it's not a problem of the world, it's a problem of the low and middle income countries. And despite being discovered 140 years back, we are still grappling with how exactly to tackle TB. And I keep writing about it and say that TB is something which will survive us. We will pass off this world, but TB will continue to stay beyond us as well. So why this persistence paradox? What's the persistence paradox as far as TB is concerned? If you look at TB, it's curable. We have effective antibiotics. We have been having those effective antibiotics for last 70 years or so now, and have been available for, as I said, for decades. TB is preventable. We have the diagnostics. We have the vaccines. And we have the preventive therapy. Now we talk a lot about this preventive therapy and it's available with us also. But it continues to be the leading single-agent infectious killer across the world. The paradox reflects the inadequacy of a reductionist biomedical-only approach. TB transmission and activation are strongly influenced by physical environment, airborne dynamics, and socio-structural determinants. So this is something that I won't go into detail, the physics of TB transmission, but my concern is that air pollution is something that is going to only exaggerate the impact of tuberculosis already around us. And we are seeing that the air pollution is something which is increasing immensely across the world, more in our part of the world than in other parts of the world. And that's going to add to what we already are having at our hand in terms of tuberculosis. But this is something that we need to have some rethinking on. And as Desmond was talking about, we have the knowledge, we have the scientific evidence which talks about this, but unfortunately, we don't find these scientific evidence in the papers that come out of WHO. Are they, or we don't translate this scientific evidence into the implementation phase. We don't apply this. The old thinking, or the thinking that is currently even going around the world when we talk of the approaches that are being used in tuberculosis, the high risk approaches, the high risk strategies, they tend to think about TB more of a disease which happens because of reactivation. So somebody picks up the TB in his early life, and because of the fact that he has strong immunity, TB gets silenced. It doesn't uh, transform into an active disease. And only when he lands up into a status which is immune deficient, that the TB will reactivate and he will show the symptoms. Unfortunately, this is the old paradigm as far as TB is concerned. And emerging evidence shows that most infections with regard to TB are reinfections or new infections, and most of them happen in the first 2 years of life. There's a data which says that around 65% of infections are new. They happen in first two years of life and do not happen afterwards. There is no binary or bimodal pattern as far as TB is concerned. Right. So this is something that we need to be thinking about when we are building discussion on this. Second is the granuloma reframe. Why this is important, granuloma? I don't go into the pathology of granulomas, but why this granuloma reframe is important, because we are seeing this actually translating into how we see TB patients now. When we began seeing TB patients maybe a decade ago, we always thought that most of the patients of tuberculosis will come to us with drug resistance, which will be secondary in nature. So say they may have extreme drug resistance or multi-drug resistance, and that will be secondary in nature. But now we are seeing patients with primary drug resistance, and that primary drug resistance is being linked to the new granuloma concepts that are being observed. So we now understand that this granuloma is a highly dynamic concept, and cells move in and move out continuously, giving rise to drug resistance, which later on translates into primary drug resistant tuberculosis, which is a huge problem. If you look at the world now, in our part of the world, we see around 10 to 12% of patients who are extreme drug resistant or multi-drug resistance, and 50 to 60% of these die even in the best of the care. So a huge amount of death is happening in our part of the world because of this extreme drug resistance or multi-drug resistance, and that is happening now primarily because of this primary drug resistance and not secondary drug resistance. Now, the other thing that we will need to be talking about when we go into the discussion points is the complexity and systems thinking. Unfortunately, at this point in time, as even Desmond was talking about, the thinking on TB is very linear. You find an infection, track infection, see whether it has developed into a disease. If it has not developed into a disease, you can leave it aside. If it has developed into disease, treat it, cure it, and send it back. That's the only thing that we do at this point in time. Despite the fact that at the same point in time, we agree to the fact that a large number of patients, roughly 30% of our patients, 30% of our population, may be harboring TB bacillus. They may not be actively transmitting TB. They may not be suffering from the active disease, but they are harboring the TB infection and are suffering from what they classify as the latent TB. So where does the systems thinking come into play? So if you look at TB, as I said, is a disease of my part of the world. It's a disease of urban poverty. It's a disease of overcrowding. And when this urban poverty, overcrowding, they combine, they lead to poor ventilation, they lead to shared spaces, they lead to increased aerosol exposure dose, they lead to higher transmission probability, greater disease burden, reduced workforce productivity, and increased poverty. If you look at the earlier slides that I presented in my opening remarks, I said that the problem with TB is that the greatest burden is among those who are vulnerable, and the vulnerable are often not able to access the healthcare that is being provided to them. Next, we talk about something that is being done across the world. The WHO acknowledges it. We run it across country now, and I'm not very convinced with what we are doing as far as this is concerned. One is tuberculosis preventive therapy, TPT. TPT is being promoted hugely across our country also, wherein patients who are supposed or suspected to be TB positive, or are in contact with patients who are proven to be TB positive, they receive TB preventive therapy. But as I said, caution needs to be warranted before we go for a general rollout. At this point in time, we say it can be given to HIV positive patients. We say it can be given to younger children. We say it can be given to household contacts of active cases. But believe me, even in those patients, we need to exercise caution when we are going for tuberculosis preventive therapy, because those chemists will tell you, those people who deal with the pharmaceutical science, they will tell you that most of these drugs are disease modifying, and they have a higher chance of exacerbating the disease per se. So we'll need to exercise caution here. Second is adult BCG vaccination. This is again being rolled out, and there's a renewed interest in it. But if you recollect, the vaccination, BCG vaccination, the effectiveness of BCG vaccination has been reported to be variable from 0 to 80%, and yet we are trying to roll it out in the current form across the world. So again, it requires rigorous trials before scaling up, as far as this part of the discussion is concerned. So this is what we have done so far, as I spoke in my opening remarks. So we wanted to take care of one part of it when we said that TB is a disease of stigma, and the focus of the disease is on individuals. You identify the disease, you identify the people, identify them as sick, try to treat them. And because of the fact that it is stigmatized, people are more reluctant not to report to the system. They generally tend to move away from the system. So what we wanted to do is that we wanted to move the concept of the disease from who is sick, the individual who is sick, to where the disease is happening or where the transmission is happening. And we developed it. Me and Matthias, we worked on this, and this was a low-cost, do-it-yourself air sampler that we worked on. And I sent to some of my colleagues in my district who work on development of these instrumentation engineers, and they developed this prototype of a low-cost air sampler. Now, the total cost of this low-cost air sampler at this point in time is less than $20. We are trying to bring it much lower, even lower than that, and maybe position it around $16 to $17 per instrument. And with regard to this, fortunately, we have been able to engage all the right stakeholders as far as prevention, treatment, management, application, implementation is concerned. Everybody has been in the loop as far as this particular project is concerned. And this particular project was fortunately an outcome of what we discussed in last Unpolitics meeting. So we did the stakeholder engagement. And what I mean by stakeholder engagement was we involved the bureaucracy of the district into it. So we talked to the bureaucracy, engaged with them, and talk to them, and we told them, look, we have been doing whatever is in our possible. We had actually exhausted the entire basket of strategies that is available with us as far as TB is concerned, and yet we are not able to reach the stages which we planned to in terms of our elimination targets. So why not try it out? And the district administration asked me the reason for why do you think this will work while others won't work? And I gave him the example of the prison that we have in the district, wherein we identified that a maximum number of a large majority of the patients of the prisoners were suffering from tuberculosis, and getting them to test on a single basis, treat them on a single basis, and making them go back to that same system is exposing them to infections and reinfections again and again. So ask them, if we have an air sampler which can be placed in a prison, if we have an air sampler which can be placed in a large household, which can be placed in a school, which can be placed in a prayer hall, we are at least able to identify where the transmission is happening. And if we are able to identify those areas wherein transmission is happening, we can zero in, target them, start an intervention in terms of better ventilation and other aerosol management techniques, so that we are able to control infection at the base. So instead of looking at the individuals, we need to look at the system, and this is where we engage with the district administration as one of the stakeholders. Fortunately, when we were engaging with the district administration, we also spoke to the Government of India accredited lab, which is there in my area, and we spoke to them and told them that, look, this is what we have developed, but we need to validate it, and are you able to help us with that validation process? And they not only helped us with that, they said, fine, we will validate it. We will provide you with the lab equipment that is going to test whether your samples have enough material to be useful in terms of an implementation or intervention strategy. But they also said that they will fund a part of it because they will provide us with the manpower who is going to take care of putting these air samplers in the right place, collecting the filters from there, transporting it to the nearest lab, collecting the extracts from the filters, and then able to see whether the extract is good enough to be useful for the future intervention. So in that sense, we were able to secure that as well, and we have received some amount of funding as well. And the third part, as I already said, was the development of a cost-effective prototype. And Yanir used to keep asking me, what's the amount of money that you will spend? I said, I won't be spending any money. Fortunately, the person who developed it, he developed it initially at a free of cost level. But when we totaled it, the amount of money that we will eventually be spending is, as I said, will be less than $20 per equipment. So even if we spread it across a large part of the district in terms of implementation, it's not going to be a very costly affair for us, and the yield is expected to be good enough.